All right. Thanks everybody for joining. Welcome to our February webinar. My name is Cassandra Theogene and I'm the Executive Assistant for BIAD. I will be your co-host today for our presentation. Today's topic is interventional treatment options presented by Dr. Haresh Sampathkumar from PAM Health. Before we get started, I just wanted to remind you guys of a few reminders. Dr. Kumar today will allow for questions. If you just have the need and wanted to ask a question while he's presenting, I'd ask that you just wait for a pause and then you can feel free to ask your questions. So there's no need to put it in the chat box today. You will not have to do that. If you're not wanting to ask a question during the presentation, please feel free to raise your hand. You can also do so by clicking on the reactions and making sure that the participant panel pops up to the right, and then you can raise your hand and ask a question then. Other than that, everybody's name is already filled in. So thank you for doing that so that we know who you guys are. And lastly, all materials from today's webinar will be sent out in a follow-up email. And now I'd like to introduce our speaker. Dr. Haresh Sampathkumar is a physiatrist with subspecialty training in brain injury medicine. He sees patients at Bay Health Hospital's PAM Rehabilitation Hospital, Dover, and his clinic to provide care for patients with brain injuries. He is also the co-founder of JH Rehabilitation, a comprehensive rehabilitation center in India, which offers services for individuals with brain injuries and other neurological conditions. He has been selected to be the brain injury medical director at PAM Rehabilitation Hospital, Dover. Aside from raising awareness about brain injuries to the community, he is interested in improving the standard care for patients in acquired brain injuries by collaborating with private government organizations and colleagues in healthcare. He is particularly interested in the empowering individuals with acquired brain injuries to control and direct their own life by independently participating in activities, including education and meaningful employment. Now I present to you our presenter of the day, Dr. Kumar.
Thank you, Cassandra, for the introduction, and thank you, BIAD, for the opportunity. So the topic for today is, although the topic for today is interventional treatment options, which was supposed to be, discussing a lot about injections and interventional options. However, I have also taken a good amount of time to go over other things as well. So just wanted to mention that in advance. So we'll move forward. So the first topic that we're going to be discussing today is post-traumatic headache. So one of the common symptoms that individuals experience after a concussion or mild, moderate, severe traumatic brain injury is headaches, and it's a common problem that we do encounter. And headaches could be of different types. It depends on the type. It depends on the character of the headache. It depends on the intensity. It depends on the duration. All of that sort of points towards what type of headache one may have. And it is important to know what type of headaches individuals have, because the treatment does vary accordingly. So these are some of the different types of headaches. I guess you could say not just for traumatic in general. They are migraine headaches, there are tension type headaches, cluster headaches, medication overuse headaches, There is cervicogenic headache. That is when individuals have real bad, constant, chronic neck pain that can cause headaches as well. That is what cervicogenic headache is. So we're going to go over a little bit in depth about each one of them. So what migraine headaches are is that they start with sort of a, what we call in medical terminology, a prodromal phase. That is, they know that they're going to have a headache. They know that something is going to happen. Sometimes they may feel nauseous. They may see things. They may smell things, hear things, and followed by the actual headache episode that they are experiencing. And once that headache sort of resolves, they end up having a little bit of a confusion, but to a large amount, exhaustion, tiredness, fatigue after that intense headache sort of resolves. So that's sort of the post-drome, as we call it. So that's sort of very characteristic of a migraine headache. So it's not that you will, certainly have all these symptoms 100%, but this is a good way to sort of distinguish migraine headaches from other types of headaches. And also, I want to mention that although there are different types, it is possible to differentiate all the different ones. Sometimes you may have more than one present in one individual. One can cause other, so that is a possibility as well. And the other type would be a stress headache, as we can call it, or tension type headaches. This happens more, the typical headache that you experience, right? You get stressed, you've had a long day, you didn't eat, you didn't hydrate yourself, and at the end of the day, you have this real bad, not necessarily bad, but you have this nagging headache that you start to notice, and it's not constant, right? It's sort of related to the situation, how the day went, all that stuff, and it can vary in duration. It could be 30 minutes, it could be 7 days, and the intensity could also differ. It could be mild, it could be moderate. It's not as severe as other types of headaches. It's usually in the mild to moderate intensity when it's just purely tension type headaches. And usually it's on both sides. It's sort of this grabbing pain, a tightening quality. It's in the back of the head. And, it's not the pulsating or throbbing, which is often much more, serious in nature. And also, stretching activities, and that can reduce headaches. Cluster headaches are a bit different. So again, as the name suggests, it happens in clusters, and that's sort of the crucial thing about cluster headaches, because they happen in clusters. That's a main characteristic. The intensity of the headache is definitely severe, and it's excruciating, and it can wake up people from sleep. And where you feel this kind of headache, as you can see in that picture, it's predominantly near the eye, right? Near the eye, above the eye. And so you may even start feeling in your temples as well. And along with that, you may feel some tearing of your eyes, or discharge from your nose, runny nose. So all of those things can also happen along with this excruciating pain. And it is often just one-sided. It's one-sided, and it can shift to the other side, but it often is one-sided. And it happens in clusters. So you could have multiple episodes of these sort of happening together. And each of these episodes could, as you can see, it could last for 15 minutes, or it could be for 3 hours. And you could have one of those, or you could have 8 of those. And the key is, they do happen in clusters, and that's very characteristic of these cluster headaches. The next one would be medication overuse. We often take Tylenol, ibuprofen, and all these analgesic medications for headaches, but in fact, they themselves, you may start with a tension headache, and you may have these real bad headaches at the end of the day because of stress, because of work, you're not eating properly, drinking properly, and you start taking Advil, ibuprofen, or Tylenol, and what happens is after a certain period of time, you can develop what is this phenomenon called a medication overuse headache. That is, you start to notice these headaches that that are different than the traditional tension headache, and the key is it doesn't go away with the normal Tylenol and ibuprofen that you take. A classic example would be someone who has headaches and takes these medications regularly, and then all of a sudden the medication stops working. The medications just don't work anymore, and then the more they take it, sometimes they may feel more headaches. So that's sort of very characteristic of this medication overuse headaches. And really, a lot of these medications that are mentioned here, can cause these, the Fioricet, Fioronol, and the Tylenol, ibuprofen as well. So these medications that we take to sort of abort the headache, those are the ones that usually put you at risk for these kind of headaches. And just to give you some triggers, right? This is more common for sort of migraine headaches. These different triggers that you can see: stress, not eating, sleeping disturbance, perfume, neck pain. So all these things are triggers. Of course, it's very characteristic for migraine headaches because they always have triggers. But it can happen in other, you can have triggers in other types of headaches as well. But these are some of the common things that you see. And
fine.
Yeah,
It's not like they're gonna.
Wait a minute, think about this. We're sending a copy of this to everybody on our list.
Okay. Can we mute? I think I'm hearing one of the audience speaking. Okay, better now. Now, for post-traumatic headache treatments, so as I had mentioned, it really depends on the type of headache one has, and if it's a regular tension headache that they're experiencing, and individuals with concussion, traumatic brain injuries, they often do have these stress headaches or tension headaches very frequently because their attention is not so great. They get frustrated very easily. They do get stressed very easily, and they often do get these stress and tension headaches. And if it's mild to moderate, it's okay to use these medications that are normally used, be it Excedrin or Aleve or Phenergan, which is a nausea medication. And if the headache is more, let's say, someone is having more of a migraine type of headache, and it's very severe headache, and it's not relieving, it continues to last, and it has that classic migraine symptom. You could use these other medications that are mentioned here, Imitrex and other types of ergot preparation. It's just a class of medications. Sometimes corticosteroids are used in this patient population as well. And what is not recommended is medications that can, when you take for a long period of time, puts you at risk for dependency, such as opiates or the Fioricet, Fioronol. Those kind of medications are not advised in this patient population. The key, the last point that's mentioned here is we want to make sure that these medications are not being prescribed, are not being advised to take more than 9-10 days a month. right? Because the more frequent they take these medications, it puts them at risk for the medication-induced headache, which we had talked about. And the treatment for medication-induced headache is really stopping these medications. And in fact, they actually have bad headaches for a period of time when it is stopped. And what happens is after a certain period of time, a week, 2, 3 passes by, and slowly the headache resolves. And that's one way to know as well whether or not this is a medication-induced headache. And aside from medications, what else could be done, right? And for these individuals, the thing with the headache is it's a very good idea to have, especially in the beginning, you're trying to understand your headache better, because it is important to know what characteristic these headaches have, because that helps to differentiate the different types, and hence the treatment will change. A headache diary is very crucial. And it's a way to sort of, especially because they don't always tend to remember what types of headaches they had. So it's even more crucial for these individuals. And when they sort of go into depth about what is the characteristics of this headache, it sort of acts as a feedback. Even after they start the treatment, they still are documenting these things, right? So it sort of acts as a feedback to them whether it's working or not. And lifestyle changes do play a key role in post-traumatic headaches, particularly the ones that I have mentioned here, right? There are a lot of triggers for these different headache types, the ones that we had the ones that we had seen in the previous slide. And this headache diary can help understand what are such triggers. You can basically look at its data, right? It's essentially data that you have, and you look at it, and then these individuals can say, well, these are the things that make this headache worse. When I take this, it's worse. At this time of the day, it's worse. When I eat a certain food, it's worse. When I don't sleep, it's worse. When I smoke, it's worse. When I don't exercise. So you identify those triggers with the headache diary, and then you basically try to eliminate those triggers, if possible. And the other things, that can also help with these headaches are, regular exercises do help. It does play a big role, and certain types of exercises, particularly conditioning exercises, because it does increase oxygenation to the brain, and it does help. And in the long term, these lifestyle interventions seem to help the most for these individuals. Lifestyle interventions, it's very difficult to do. It's always easier to say it than do it, but studies have shown repeatedly that when this is being identified and implemented accurately, this seems to give them the most benefit among all other interventions, medications, or integrative treatments like acupuncture, whatever, injections. Best long-term option for these patients. So that brings me to the next topic. What are the other options that are available? If it's a cervicogenic headache, that is, it's coming from the neck, a lot of physical therapy exercises, manipulation can help, and some cognitive behavioral therapy, biofeedback, stress management. These are some of the other options, integrated treatment options that could help these individuals. So injections. So the simple injection would be trigger point injections, which are basically just superficial injections into the muscles, either in the neck or in the back of the head. They're very superficial intramuscular injections. They give good relief if the type of headache one has is more coming from the neck, and it's more because of the muscles that are very tight that they have headache. And if the headache is because the nerves in the back is entrapped, what happens is when these individuals have real bad headaches, it tends to tighten up. The muscles tend to tighten up, and they press on the nerves in the back of the head, those nerves called occipital nerves, which you may be able to see in the picture here. These are the occipital nerves. You've got two occipital nerves on each side. So the muscles tend to tighten up and can push on these nerves, which then cause sort of shooting pain and tightness in the back of the head, that kind of stuff. And blocking that nerve, which is also a very superficial injection, is quite effective. The last injection option that is available, particularly for a migraine headache, is Botox. This is usually used as a last resort. I'm sure most of us are aware of Botox being used for cosmetic purposes, but it has a large usage in chronic migraine headache, which does happen, especially when these post-traumatic headaches sort of become chronic. And basically that, I would like to bring your attention to the picture in the right bottom corner. And, the dotted spots are the areas where these injections go. So it's basically, a few injections. It's a very thin, tiny, superficial needle that is used for these injections. And you distribute them. Small amounts are being injected in all these dotted spots that you're seeing, sort of in the front, in the sides, in the back, and in the neck. Especially in individuals who have tried different things and nothing has helped, this is one of the treatment options that is quite promising. It is not a treatment option that sort of aborts the headache. It is one of those treatment options that is more as a prophylaxis. So you get it the first time, you get a certain percentage relief, maybe 30–40%. And then the second time you get it 3 months later, you get about 60–70% relief. And the third time you get about 80% relief. And then third, fourth, fifth time you get it, it's the same percentage each time after that. But it has that cumulative effect. But it's quite effective, this treatment. The other common issue that we encounter, particularly not so much with mild TBI concussion, but a moderate or a severe TBI is weakness, paralysis on one side, which eventually are on both sides sometimes, and eventually end up developing very bad tightness in the arms, in the arms and legs, as what we call it as spasticity, right? And that's another common complication that we encounter, which is quite uncomfortable and painful for these individuals. Basically, what that is that using a lot of jargon here, but basically it's a tightness of the muscles, and that is happening as a result of insult or injury to the brain, and sometimes spinal cord as well, but for our purposes, injury to the brain. And so the reason why this happens is normally it's sort of the entire human body is sort of yin yang, right? And you have a default way of keeping the normal sort of rhythm. Your arms and legs are not too loose. At the same time, it's not too tight, because there's a happy medium, and there are two separate sort of tracks that comes sort of from the brain that sort of affects this. And it's technically one track, but the default state for any human is tightness. That's actually sort of the default state. If you were to think about it a certain way. So the good example would be when someone passes away, right? We see rigor mortis sort of set in, right? Your muscles get very tight, when their muscles get very tight when they pass away, right? That's because that's sort of the default state when there is no inhibitory impulse coming from the brain. That's the normal state. And when you have those inhibitory impulses, then you have that balance between not too loose and not too tight. And of course, when someone has an injury to the brain, those inhibitory impulse from the brain is not coming down to these muscles, which then end up having, which then end up causing real bad tightness in the arms and legs. So that's sort of why it happens. And when it does happen, it causes a lot of problems, spasticity, which is that these individuals become very tight, and they're in discomfort, they are in pain. Because of that, they're not able to move, which puts them at more risk of not exercising, not recovering, end up developing blood clots, end up developing ulcers. Their bones are not as strong because they're not up and moving about, and your bones only are strong if you're bearing weight. Also, not to mention the mental impact that it has, when they're not able to get up and move about, and they're in constant pain or discomfort. And sometimes it may not be that they're in pain. It might just be that it's just so uncomfortable, and sometimes it could be cosmetic. They don't want their arms and legs to be tightened up and flexed and be a certain way. And sometimes it could be as simple as hygiene, because when these muscles get tight, it's very difficult to clean the areas. When your hands become very tight, it's going to be very difficult to clean the area underneath the hand or underneath the wrist, and that causes skin breakdown and infection and things of that nature. So that's why it's a big problem, or it can, and sometimes it might be as simple as, if there is tightness, they tend, in the foot, for example, they tend to drag the foot. They're not able to clear the floor properly, which puts them at risk for falls, and they fall down, right? So that's another issue as well. But spasticity is not necessarily bad. It's really, it is contextual. It's where, the question of where exactly is this tightness? How severe is it? Is it helping them in any way? Sometimes it can be helpful. So, and sometimes it's the initial stage before these individuals start to recover, meaning that start to gain strength in that arm or leg. And the treatment should be initiated when there is a clear goal, when it's affecting their function, when they're in pain. These are some of the things that I have mentioned before, the things that I mentioned in the slide. So, their function is getting affected. They're at risk for falls, and the foot is very tight, or their arms and legs are very tight, and they need to be positioned better. Otherwise, it's going to be very difficult to clean those areas. So they couldn't be positioned properly in the wheelchair. They couldn't be positioned properly in the bed because of the tightness, or it's causing a lot of pain, or it's causing contracture, meaning that it's much more severe tightness where you can't even move anymore, or you want to avoid it from happening. So we always want to have a clear goal with the spasticity. Only then we want to treat it. And there are various ways to treat it. There are medications available, therapy, stretching exercises, braces. There are a lot of bracing that can be done. So all of those are treatment options. Also, the other options are injections. There are a lot of injection options available as well. Botox, nerve blocks, baclofen pumps. That's an option. And if we were to sort of move even, I think I skipped a couple of slides. I don't know if it's acting slow. Let me stop back here. Yeah, there we go. So So there are some injection options available, be it Botox or nerve blocks or in baclofen pumps. And there are surgical options available, especially when it's not so much spasticity anymore. At this point, it's become more of a contracture. So these are some of the surgical options that are available, which we can discuss. So this is sort of one slide that sort of tries to capture everything, the medication options, the stretching options, physical therapy, and the injection options, the surgical options, in all those different things put in one slide. And in the past, it was always thought about, treatment for these individuals with spasticity was always thought about as, we want to start with least invasive, most invasive, and then we slowly build up. From least invasive, you move on to most invasive. However, that has been heavily challenged, and the way of thinking now is it's contextual. It depends on the context, and it depends on so many other factors. When someone is really tight and they're in a lot of pain, and we know for a fact that therapy is going to be difficult for them, or we know that they're going to benefit from injections immediately, then there is no virtue in going step by step, because they're going to be in discomfort, and we know that in advance. So it really depends on what is the context, and at what point, how much is it affecting them, what are we trying to achieve. So based on that, it doesn't have to be the least to most, it's just what is most appropriate for that particular individual, is how we want to think about it.
Dr. Kumar, this is Cheryl. I just wanted to let you know that we did have a question from Cassandra. Cassandra, if you want to unmute yourself, you can go ahead and ask Dr. Kumar.
Hi, thank you, Cheryl. Dr. Kumar, I do have a couple of questions. One was relevant to the cluster headaches that you mentioned earlier.
Mm-hmm.
And I do not understand the difference between the meiosis and the, what is it, ptosis or ptosis?
Mm-hmm.
Can you explain that to me, please?
Sure. Yeah, it's meiosis just means that your pupils are constricted.
Okay.
Ptosis just means that your eyelids are drooping.
Okay, thank you. And my other questions are actually with regards to the migraine headaches. So I have been diagnosed with both migraine headaches and seizure, focal seizure. And my ENT mentioned to me that it's potentially an issue that my migraines could be mimicking seizures. How do you differentiate something like that?
Yeah, that's very difficult. The best way to do that one would be if, so as you know at this point, right, that is EEG is only effective when the seizure is happening. If the seizure has already happened and there is no seizure happening, EEG will say the brain is normal or there's no seizure activity going on. So I think having an EEG done at that point in time, that's the only way to capture it, to know for sure whether that was just a migraine headache or that seizure is mimicking as a headache, which can happen as well.
So may I ask another question? I'm sorry, finish and then I'll.
Yeah, so the best way to know would be, doing an EEG at that point in time. So then the question of how would you do an EEG at that point in time? There are, this is a bit more, involved, but the epileptologist could suggest either a longer 24-hour EEG monitoring, or sometimes they do like a stress EEG. They put you under stress and then they provoke seizures when they're monitoring you. So there are ways to do it, but the question also is, do we really want to go that far to know it, or do we just treat one or the other and then just find out? If you treat migraine, the headache improves, then it's migraine headache. If you treat seizure and the headache improves, then it's seizures. Okay,
well, I've been treated for both, and I will say the Botox is what I receive, and it's been a godsend, and the carbamazepine works very well too. But I guess my subsequent question is with regards to even the EEG testings, because I've been sent for 2, and I've specifically indicated on many issues that vibration is what triggers me most for seizure. And it seems like with the basic EEG testing, nobody ever sets up a test to test for vibration. as a trigger. Is that something that is even considered in the healthcare community?
Um,
Because I know it's a rarer instance.
yeah. I think I want to say I don't know because I'm not an epileptologist, so probably they could answer because I don't do EEGs or I don't read EEGs.
Okay.
So it would be the neurologist or the epileptologist that would have to answer whether it seems theoretically possible to do it, but why it is not being done or is it being done? I'm not sure. I'll have to ask my colleagues.
Okay, I appreciate that. Thank you.
You got it. Okay, so that's the summary. So this is just a slide that, and it's a bit involved. I just want to tell you that all the slide says is that the medications act on receptors, and these receptors are present in your muscles, in your spinal cord, and some of these receptors are also on the brain. But it's really the spinal cord and the muscle level where this medication acts, thereby causing muscle relaxation. Because these receptors are also in the brain is why when you take some of these muscle relaxant medications, or when these individuals take these muscle relaxant medications, they get tired and sleepy because there are some of these receptors are also in the brain. So the other option is, again, I'm using Botox, but I want to be precise in saying this. It's actually botulinum toxin because that is the generic name. Botox is just one company that makes the botulinum toxin, and the most common one, the most well-known. There is Xeomin, there is Dysport, there is Myoblock. So there are a lot of botulinum toxin that are available. And it is also an effective treatment, botulinum toxin, for spasticity as well. And these pictures are just to show sort of where this injection goes. Basically, again, it's a muscular injection because the problem with spasticity is the muscle tightness. So one would have to identify, the doctor has to identify which of these muscles are tight. Again, as I said, the context is, what is the goal? Is the goal making them to walk better? Then we want to find out if that's the goal, then let's identify the muscles that are preventing these individuals from doing that, and let's relax those muscles. We don't have to inject every single muscle that's tight. That's not the purpose. It's what is the goal, and let's work backwards and find out what muscles are preventing them from doing that. It's muscular, and it's not just one muscle, it's usually more than one muscles that are often involved. And how that works is that again, I want to bring your attention to the picture on the right bottom corner. You're seeing a lot of it's a busy page. You're seeing a lot of these little vesicles, right? Basically, where this is that this whole thing is in the junction between the nerve and the muscle. That's what this is. It's the junction between the nerve and the muscle. So the blue stuff is your nerve ending, and I guess you can say the red or the pink in the bottom is sort of your muscle, and that's the junction. And you can see that there are some the vesicles are releasing these tiny they're actually neurotransmitters that are approaching the muscle, and these neurotransmitters are sitting on these receptors on the muscle, and that's how normal muscle contraction happens. And basically there is excessive release of these neurotransmitters, and these neurotransmitters are occupying a lot of these receptors in the muscle in a very tight spastic individual. So basically what Botox or botulinum toxin does is it prevents the release of these neurotransmitters, thereby decreasing the transmission of impulses from the nerve into the muscle. So that's how it causes relaxation. And the good thing with Botox or botulinum toxin is we can precisely go to that particular muscle and inject it, thereby eliminating the whole absorption by your stomach, metabolized by your liver, metabolized by your kidneys, because individuals who have kidney problem or liver problem or sometimes these things can also go to the brain, right? These receptors are also in the brain. So it eliminates all of that and it just goes exactly where it needs to go, which is the muscles, and thereby eliminating any kind of, drowsiness side effects or tiredness side effects. It's much more effective because it goes exactly where it needs to go. It usually takes about, a few days to start noticing some difference, up to a week. And I would say by about 2 to 3 weeks is when it starts to peak, and the effect lasts for about 3 months, and then you keep repeating once every 3 months. As I had said, for Botox for the migraine, the same principle applies here as well. It's a cumulative effect. The first time they get it, they get certain percentage relief, and the second time more, third time even more, and then third, fourth time they sort of peak, and then every time they get it, they get the same relief each time. So that's sort of the cumulative effect that they get from this. And the
Dr.
possible
Kumar, I
side
think
effects-
Dee has a question.
Yeah, I'm listening. I can hear.
Wait a minute, sorry, how does that affect people with diabetes with the direct injection? Does that raise their numbers or no? Because you said it's going right to the joint.
Yeah, exactly. No, it does not. Yeah.
Okay, that's good to know.
Yep. Yeah. If it's cortisone, then you're a bit concerned because cortisone can raise blood sugar, blood pressure, but no, not with Botox.
Okay, that's good to know. And the nerve blocks that you mentioned, how do they differ? How does a nerve block differ from the botulinum toxin?
That's the next slide.
Okay, good. I'll wait for it.
So the weakness is a possible side effect, and as with anything, you can there are potential side effects. So weakness in the legs or the muscles where it's being injected, if too much is being injected, and botulinum is a toxin. So if too much is being injected, which again this is not done in the medical setting, but then they can go into botulism. Botulism is a condition where you are completely sort of flaccid and paralyzed, right? So that's the other extreme. But yes, so those are some of the things to look into. So this is just to show some sort of a pre-injection and post-injection disclosure. These are not my patients, but just wanted to mention that. But so the first picture on the left, so as you can see, the foot is basically turned inward, and when they walk on the side of the foot. You can see the right foot is turned inward, and they walk on the side of the right foot. And after a few injections, and presumably 2 months, 3 months later, they are now able to have a flat foot, right? So that's one. And same thing with the second picture as well. As you can see, the foot is not as turned inward as the person in the first picture, but it is a little inverted, a little sort of turned inwards. And that's evidenced by the fact that there's a small callus that we can see at the bottom of the foot in the second picture, right? And again, after a couple of months after injection, we could see that they're able to now bear weight. And then this is the third one is again the same thing where the big toe is just coming upwards, pointing up. It's not going down, and the little toes are going down. Big toe is coming up. But 2 months after the injection, as you can see, the little toes are not as pointing downwards, and the big toe is not as pointing upwards. It's sort of, in the midline. So phenol is what is often used for a nerve block. So we saw how the botulinum toxin or Botox acts on the neuromuscular junction. The phenol, which is used for the nerve block, basically acts on the nerve itself. As we know, the nerves are basically wires, and phenol, it basically affects the transmission of these signals by destroying a crucial sheath, a nerve sheath, which helps in faster conducting of the electrical impulses through the nerves. And basically phenol just damages that sheath, for a lack of a better word, that sheath, or the coating, whatever we want to call it. It basically destroys, for lack of a better word, I'm using the word destroy, it damages that part of the nerve, thereby decreasing the impulses. Again, pain is an impulse. Tightness is still an impulse that is being carried, right? So you want to, prevent the transmission of impulse, and that's how it does it, by basically blocking or damaging the sheath or the outer coating of the nerves, which helps in transmission of impulses. It's much more quick, and it's much longer lasting. It's much more cheap, and you don't need authorization to get it. The downside of it is it can cause pain, or you may have experience, because it's the nerve that is being blocked, like a nerve pain. It's a different type of pain that you may experience, a burning sensation, like a traditional nerve pain type of nerve problem. Symptoms is what one may experience. Not that they will, but they might, and there's a higher risk of that compared to Botox. It's quite an effective treatment option, and they sort of supplement each other. They sort of go hand in hand, because there's a limitation with Botox. You can only inject so many units at a given time. Otherwise, they end up having botulism, right? And phenol at that time could be a great addition to that. So it has its place, and so it's quite effective for certain types of problems. And of course, limitations, as I had mentioned, it's the side effects that go along with that. And this is someone who did receive phenol. So first video. So I get both surprise. So this video that I'm playing is before they had any injection. This was they were so tight, they could not put the foot down. So this was before they got any kind of injection. And then the second video that I'm going to play is after. So this is after. So this is within 5 minutes or so, because this acts much quicker than Botox. Okay, the last one that I want to discuss is intrathecal baclofen or baclofen pump. Basically, this is another treatment option. Baclofen is a muscle relaxant, and it's a good muscle relaxant. We know where it acts. We saw the picture. It acts in these receptors. All these muscle relaxant acts on these receptors in the spine and the muscle. But when we take it through the mouth, it it has to be digested, and then it has to be absorbed. It has to go through the liver and the kidneys. Then it through the blood, it has to go to the area of interest, which again is this the muscle, right? So when you take a certain amount, let's say 20 milligram or 10 milligram of baclofen, what ends up getting to your muscle is such a small quantity because everything gets absorbed at different places, goes to different places, right? So intrathecal baclofen or baclofen pump is a very efficient way to get that baclofen directly into the area of interest, which again, a lot of these receptors are in the spine, as I had indicated in the very beginning. So that's basically what that is. The purpose is to get the baclofen into the spine where these receptors are. And often this is used for individuals who have, again, major limitation, significant spasticity. All these other treatments are not as effective for them. This is a quite effective treatment option. And it's a surgical procedure for the actual implantation of this pump, as you can see. This is this is the pump. This is the actual pump. This is how it looks. It's a metal, and there's a small opening in the middle, and there's a catheter, there's a wire. It's very, very thin. It's very, very thin. As you can see here, the pump is here. The catheter goes from here all the way into the spine over here. And basically, you put in medication into the pump, and the pump is programmable. So then it will send the medication through the catheter from this reservoir, right? Pump a reservoir through the catheter. Right here, reservoir, catheter into the spine where these receptors are. As you can see, the typical dose for the pump is less than 0.1% of what is being taken through the mouth, and it's much more effective even in that dose. And that's what the pump is. And basically, you could see that this device is talking to the pump, and that's how it is being programmed, because we want to tell the pump how much medication we want to send, at what quantity, and how fast, and there are different settings available. So, and we want to be able to program that pump the way we want. So this is just to show how that is done. So again, this is just another slide that shows that. Here's the pump, the reservoir goes to the spine, and I want to bring your attention to this slide where you could see the pump here, the reservoir or the pump, and the catheter, and you see this device, right? Like a tablet. And this is the device that talks to the pump, and this is how we program the pump using this device. So you just literally put this on top of the belly, because this pump is implanted underneath the skin, in the front of the abdomen, underneath the skin. Maybe this is a little bit better. In front of the abdomen, underneath the skin, and then the catheter just goes into the spine. And this is how we have the device communicate to the pump, and we make the adjustments on the tablet, and it gets communicated via this device to the pump, and then the pump does what we want it to do. And it's a surgical procedure. A neurosurgeon, interventional spine doctor, they have to be trained in placing these pumps. But before such a big surgery is being done, it's not a big surgery, but before a surgery is being done, you would want to know whether someone will benefit from it. For who we think is getting this will benefit from it. So there is a way to find that out. So the way to do that is doing a one-time, like a cortisone shot in the back, or epidural injection, as we would call it. Doing that one-time injection, it's not technically in the epidural space, it's a little bit deeper than that, as you can see in this picture. And you inject it into the space, and you just wait for a few hours, 4 hours, 5 hours, and then compare how they did before and how they did after. So before this procedure was done, this one-time epidural injection was done. Again, it's not actually epidural, it's a little bit deeper than epidural, but I'm using the word epidural because it's easy way to know. It's like a back injection, basically. A one-time injection, and then how were they before and how did they do 4 hours later? And that's a good way to know whether or not this is a good treatment option for these individuals, whether or not they should get the pump implanted. And so this is just the medication vial, how it looks. And once every few months, this medication has to be, refilled, take out the old medication and put in a new medication. And it's just an office procedure. It takes 5 minutes. They come in, take out the old medicine, you put in the new medication, and then program it however we want. That's usually how it's done. This just talks more about why is intrathecal more effective than oral, and the advantages of it, right? Which is all the side effects that are seen with the oral medication. You don't have that with the pump, because again, it goes exactly where we want it to. It's programmable. It effectively reduces spasticity. It's reversible. We can set it however we want. We can change it. Again, always have a goal for any kind of treatment options. This just basically talks about, when patients come in, we identify them, then we do what is called a screening. Screening is what I had mentioned, that one-time shot in the back, and then they are a good candidate, then you have the pump placed. And then once the pump is placed, then we want to adjust the dose however we want it to, and then rehabilitate them. And then once every couple of months or so, they will have the medications refilled. That's usually the process. This just talks about the overdose, withdrawals, contraindications. Again, there's always downside or possible risks with everything. So these are some of them. So just want to, this would be my last slide. I just wanted to show this. I don't know if this is going to play. Can you all still see my slide?
Yes, sir.
Okay, so this is just a pre and post trial, pre and post baclofen trial.
I'm continuing. Go ahead.
Pre and post trial. So this person
I can actually just take the link and send it to everybody.
one shot.
Because it's gonna
Before
open.
they got the one shot injection in the back. This is they didn't have a brain injury. This was a spinal cord injury. But you can see how tight they are. The arms, the legs are very tight. They're having a hard time.
Haresh, we're not seeing the video, but what I can
You're
do
not?
is, no. It probably opened up on another screen. We
I
just
see.
see the
Okay,
link.
then perhaps
I can send it to everybody. So that they
I
can see.
think that might be better. Let me go back to the screen then.
No worries. Guys, I will send you guys the link with some follow-up materials, a copy of this PowerPoint. Haresh, would you like me to PDF it? We can send it to everybody. Is that okay? Okay.
Yeah.
So thank you so much. Actually learned a lot. Didn't know all this stuff about migraines, but now I do. If anybody, thank you everybody for joining actually. And if you guys have any questions or wanted to reach out to Haresh on any of this, I will be certain to include his contact information in our follow-up email for tomorrow. Just wanted to thank everybody for hopping on and spending their hour with us today for our webinar. Haresh, did you have any final comments you wanted to say?
No, thank you for having me, and yeah, I'm happy to answer any questions that audience may have, and if they have something later, it can be emailed to me, or you can give them my contact information. I'll be happy to answer them.
Thank you so much.
Of course.
I also would like to make sure that everyone on the line today is aware that the next series, the next webinar in our series is March 15th. It's also at 2:30, and it will actually be a 90-minute session, and it's specifically designed for caregivers. So we invite you to share it in your networks, in your areas of influence, really looking for caregivers to join us. The American Red Cross will be facilitating. It will not be recorded because they want people to share freely. So encourage as many survivors as you can to join us live. We actually have 3 sessions throughout the coming months with the American Red Cross. This is session number 1, and it really is going to talk about effective communication for caregivers. So it's a great place to start. Please share it in your networks. Again, March 15th, 2:30. And I think that's it. Thank you so much, Dr. Kumar. This was really, as Cassandra said, very interesting. We did record it, so I know that folks will access the recording, and we appreciate your time and talent. Thank you.
Wonderful.
Yeah, I
Thank
already
you.
got one person that's going to watch it afterwards because she couldn't get logged on in time because she was in another meeting. So,
No problem.
yeah.
Good to know.
All
Thanks,
right.
Cassandra. Thanks, Suzanne. Thanks, Dee.
Bye.
Thanks, everybody.
you.
Bye-bye.